Now it's my pleasure. He's already coming to the stage to introduce Mehdi Brahmi from France. I think it's from Lyon. And and here you have to use the microphone, unfortunately, to get the recording for the session.
Okay, thank you so much for the invitation. So good afternoon, everyone. My name is Mehdi Brahmi. I'm a medical oncologist, indeed, from Saint-Léon-Bérard, Lyon. And I will talk about the current developments in GIST research. So, of course, the current development in GIST research are depending. Yes? Yes, of course. Yes, you can have it, of course. So, to introduce this talk, I would say that the current development in GIST research will depend on what do we need. So I asked to myself the question, what do we need as of today in GIST? We need, of course, to improve patient survival. It means that for localized disease, we need to decrease the risk of relapse. And for advanced disease, we will need to have new drugs, new combination maybe, and also new strategies. And what do we need also is to improve patients' quality of life. And as it was well explained at the end of the morning, we need to communicate everyone, patients, biologists, researcher, and physician in order to better answer to those questions and go to the right way. After saying that, now we can discuss about the issues and the field of research as of today in GIST. With different parts of my presentation, it will be separate in three parts. First, we will talk about the localized disease and the risk of relapse and all the research doing about adjuvant therapy. The second part will focus on advanced disease and the issues of imatinib resistance with, of course, primary and secondary resistance. And the last part, we'll talk about the quality of life and the supportive care. So to begin, the localized disease and the risk of relapse, we will talk, of course, of adjuvant therapy. And the decision of adjuvant therapy is going more and more complex because of what have been said by Eva just before, because of this GIST molecular classification, which is more and more complex with the help of what we called previously NGS. And with this GIST molecular classification, which is more complex, we are now able to go beyond the Mietinone and UNSU risk classification. And why are we going beyond this classification? Because you have to know that the mutational status of GIST has first a prognostic value. We have previously shown that the mutation has a prognostic value. You can see here an example of what have been presented by Agnès Wozniak in CITOS in a few years ago that shows that the PFS of patients is depending on the subtype of mutation with mutation that has a good prognosis. For instance, the D842V PDGFR mutation, which is a good prognosis factor, whereas some mutation like the deletion 557, 558 on exon 11 of KIT, which is a poor prognosis factor. And the second important thing is that the mutational status not only is a prognostic value, but has also a predictive value. I mean that we will have some mutation that will predict the response to the treatment, imatinib, and we will have some mutation that will predict the resistance of the treatment. And the best example is the PDGFR mutation D842V, which lead to a totally different conformation of the protein. That means that imatinib will not be able to bind the protein and to be efficient. And we have shown previously in preclinical model and also in clinical study that imatinib is not efficient in this subtype of tumor. So with that, you know now that this mutational status will have an impact on adjuvant treatment decision, because before deciding on the adjuvant treatment, you have to look at the mutational status in order to know what is the prognostic value of the mutation that we have detected, and what is the predictive value of this mutation. And you will have two main options. The first option will be some case of high-risk methylene GIST, but with a mutation that is resistant to the treatment or good prognosis. And the perfect example is the PDGFR D842V, that is good prognosis and predictive of resistance to imatinib. So, of course, you won't prescribe adjuvant imatinib. And the other example is the case of low or intermediate risk GIST, but with a bad prognosis mutation, such as this mutation on exon 11. And your decision will be depending on the mutational status. Just a brief clinical case of a patient that I treated a few years ago with this big tumor. We performed a biopsy that showed diagnosis of GIST. The tumor was localized, so surgery has been performed, and you have here the pathological report. It was a gastric GIST with 3 mitosis for 5 millimeter per square and 17 centimeters for the size of the tumor. When we look at the risk classification, it is a high risk because of the size of the tumor, but the molecular biology show that there were D842V mutations. So, of course, we did not prescribe adjuvant treatment, and it was now a long time ago, and the patient didn't present any relapse. So going further, Eva just told us a few minutes before that the genetic of GIST is more complex that we thought, and indeed we see that depending on the subtype of GIST, we have some GIST that have what we call the high genomic index. It means that the genetic of the GIST is very complex with a lot of loss of genes that you see in green and gain of genes and chromosome that you see in red. And some subtype have a low genomic index. It means that there is not many gain and loss of genes. And we have seen in intermediate risk GIST that is a quite heterogeneous group, that we can better classify patients depending on the genomic index. We performed a retrospective study with 82 patients with intermediate risk GIST. And in this result, we show that the relapse occurs mainly in those intermediate risk GIST that shows a higher genomic index. That is why we perform this study, GI GIST, where patients with an intermediate risk GIST can be enrolled. We do a genomic index. If the genomic index is low, then the patient has a simple surveillance. And if the genomic index is high, we propose to randomize patients between surveillance and imatinib adjuvant. This study is close to recruitment, so of course we have to wait for the results. And to finish about the adjuvant part, we question, of course, the treatment duration, because we know that imatinib 3 years is the standard for high-risk GIST, and we have 2 studies that question the duration of the treatment, the French studies and the Scandinavian studies. The questions of the studies are whether more prolonged duration of adjuvant treatment by imatinib would be useful, of course, useful in terms of disease-free survival and overall survival. And the IMAGIST study design is now closed, and we have some partial results. Just to explain, it was only patients with high-risk GIST, and patients were randomized between imatinib maintenance after 3 years to 6 years of adjuvant treatment, and imatinib stop after 3 years. So the primary objective was the disease-free survival, so the time to recurrence. And the secondary objectives were overall survival of patients, but also the safety and the time to imatinib resistance. So the first result of the study have been presented at ESMO Sarcoma a few weeks ago, when you see that the disease-free survival is much better, significantly improved by the fact of prescribing 6 years of imatinib that you see here, comparing to 3 years, with disease-free survival of 87% in the maintenance arm versus 55% in the stopping arm. And here you see two secondary endpoints. On the left, you have the time to imatinib resistance, TTIR. It means that continuing imatinib for 6 years does not create more frequent resistance to imatinib for these patients. And here you see the overall survival that is, as of today, the same between the two arms, but the results are immature. So the conclusion is that extending the adjuvant imatinib treatment from 3 to 6 years confers a significant reduction of recurrence in patients. It seems that regarding the results, the risk of developing resistance to imatinib does not increase when you do 6 years in comparison of 3 years. The overall survival is still immature, so we will need long-term follow-up in order to see if there is a benefit in terms of overall survival. And the IMAGIS trial provides some evidence, maybe in favor of extending adjuvant imatinib, but we will need a longer follow-up, of course. So are we facing a new therapeutic standard? As of today, I'm not able to tell you, but we will see maybe in a few months after the results are more major. So that is for the first part of localized disease and the risk of relapse. Now we are talking about advanced disease and imatinib resistance. And again, like in the first part, when we want to talk about imatinib resistance, we have to keep in mind this molecular classification, because without knowing the molecular classification of GIST, we cannot understand what are the explanation of the imatinib resistance. And the first part will be the primary resistance. The primary resistance could be explained by a KIT or PDGFRA resistance mutation. As I told you, the PDGFRA D842V is the more frequent KIT PDGFRA imatinib resistance. And now we have a new drug since a few years ago that is called avapritinib. And as I told you, imatinib is not able to bind the kinase because of the conformation that is very changed by this specific mutation. But avapritinib is able to bind the kinase. And we have shown in preclinical model that imatinib is not efficient, but avapritinib seems very efficient in this subtype of GIST. So we have now the result of this phase 1 navigator that included GIST patients, including D842V mutants. Just a quick reminder of the safety. We have some adverse event that we are used to as a medical oncologist, but we have a specific adverse event, which is neurocognitive toxicity that occurs in a lot of patients, and for which the mechanism is not well understood. So we have to be careful. Anyway, when we focus on the D842V cohort, there were 56 patients with a very high overall response rate, 88%, and a high PFS. So that led to the EMA approval, and we have now access to this drug specifically for this subtype of mutation. The other category of primary resistance to imatinib GIST are the GIST without KIT or PDGFRA mutation. And we have seen previously that there is different subtype of KIT wild type, the one with abnormalities on SDH, and the one with other mutations such as NF1 or NTRK fusion. For NTRK fused GIST, we have now TKI, some tyrosine kinase inhibitors that target specifically this tyrosine kinase receptor. So there is no reason to treat those patients with imatinib or other drug that target KIT or PDGFR because it is not the tumorigenesis factor. So we have, for instance, larotrectinib, which is a TKI that target NTRK and very useful in this situation. Here you have the study where at least 3 patients with GIST and TRK have been included. For NF1 GIST, it is more complicated. As of today, we have no clear efficient treatment, even if we know that the problem for NF1 GIST is the mutation on NF1 that could lead to activation of this pathway. So, of course, there is some rationale to use MEK inhibitor, and we have this study and maybe other study that could target this pathway. And then for SDH deficient GIST, we know now that imatinib is not efficient. And what we know also is that the deficiency of SDH in the cells, in the tumor cells, creates mainly two things. The first is very high angiogenesis. And the second is a hypermethylation of the genome. So maybe it could be 2 targets for this subtype of GIST. And in fact, when we look at the result of sunitinib, which is a KIT and PDGFR inhibitor, but also a VEGF inhibitor, so an anti-angiogenics, sunitinib seems to work at least a bit in this subtype of GIST. And regarding what we called hypermethylation, temozolomide is a chemotherapy that could be efficient in this subtype of GIST, and we have this result of the phase 2 presented last year at CITOS that show some kind of response and the signal of efficacy in this subtype of GIST. So we were previously saying that chemotherapy doesn't work in GIST. I think that yes, we should keep in mind that chemotherapy is not the good treatment for GIST, but SDH GIST are very particular, so maybe chemotherapy could be useful in this subtype with temozolomide. For secondary resistance, I will go fast. Eva presented well the mutation of resistance. We have now ripretinib, which act by binding both the activation switch and the switch pocket of the kinase. And in preclinical models, we have seen that ripretinib seems to work both in primary mutation and in secondary mutation. And we have, of course, this study Invictus that tested ripretinib in the 4th line after imatinib, sunitinib, regorafenib, and then patients were randomized. You see here that there were a benefit in terms of progression-free survival. And there were also a benefit in terms of overall survival, even if the patient could receive the treatment after a crossover when they were randomized in the placebo trial. And in terms of new drugs, we have also a lot of new drugs that are coming. We have this drug, NB003, that is currently testing in a phase 1 trial, and we have also the other drug IDRX42 that is currently testing in another phase 1 for GIST that are resistant to imatinib. In terms of combination, there is a lot of combination that are studied with imatinib, with ripretinib, but I would like to insist with this combination, sunitinib plus bezuclastinib, the phase 3 trial is currently ongoing. Patients are in 2nd line. They have received imatinib. Imatinib has worked for maybe 3, 4, 5 years. And then the theoretical indication is sunitinib in 2nd line, and they can be enrolled in this study where they are randomized between sunitinib, the standard treatment, and sunitinib plus bezuclastinib. And importantly, patients that are randomized in the sunitinib arm, if the disease progress, they can after receive sunitinib plus bezuclastinib. Here you see a clinical case of a patient that I recently included in the study. He had exon 11 mutated GIST treated in first line with imatinib. I don't know what is the secondary mutation. Anyway, as he shown a progressive disease, I include the patient, and he had been randomized in the arm with sunitinib alone, showing at the first CT scan a progressive disease. So the patient had received the bezuclastinib as a crossover, as I told you, and the next CT scan is in complete response. So it's quite amazing how we see that it works on the primary of the secondary resistance. Immunotherapy, we have talked about the microenvironment, and what is quite disappointing is that indeed there is some lymphocyte and there is some predictive factor that could tell us that immunotherapy could be efficient in GIST, but it doesn't seem to be the case. There is only small studies where we have seen a small signal of response. Anyway, there is some studies with immunotherapy, but mainly in combination with imatinib or regorafenib. But for the moment, we don't have real data that show efficacy of immunotherapy in GIST. And new strategies, yes, we need new strategies because we are talking about, of course, primary mutation, but we are also talking about secondary mutation and how do these secondary mutation impact on the way we treat patients. For the moment, it doesn't impact. We do after imatinib, sunitinib, regorafenib, ripretinib, and it doesn't depend on the secondary mutation. But maybe this study will change our standard because regarding the previous study, it seems that ripretinib works better than sunitinib in the case of exon 11 primary mutation and exon 17 and 18 secondary mutation. So for those patients, we have to prove it with a phase 3 randomized study, and those patients will be randomized between ripretinib and sunitinib in the second line. So last but not least, the quality of life and the supportive care. Before doing this presentation, I went to the data that we have in the NetSarc database, which is the database of the French sarcoma group. And I look at the survival over the time. So just be careful with this data because it's always median survival. So for a patient, it doesn't mean a real thing, a median of survival. Anyway, the historical median survival was 12 months for GIST, for metastatic GIST patients. And now, what do we have in the NetSarc database? We have a median overall survival of more than 7 years for patients. And we see that patients receive at least 3 TKI. So it means that the quality of life of those patients is so important, and we have to be careful. And obviously, we also have to be careful because we see that imatinib is a good targeted therapy. But when we look at the genome of sunitinib and regorafenib, you see that there is a lot of off-target, explaining all the toxicity, and it is clearly shown in the regorafenib phase 3 that lead to the drug approval with more than 50% of grade 3 toxicity. But surprisingly, even if it is a highly important subject, the literature is very scarce. As of today, I have found 2 reviews on quality of life of GIST patients versus control population. Only 7 reviews of quality of life with a specific TKI, for instance, quality of life of patients treated with sunitinib, and only 1 general review of quality of life of GIST patients and TKI. So it's not much. Just to show you the disease impact, we show that the disease impact on the quality of life of patients, of course, with more fatigue, more pain, more more nausea, etc. And we have now more and more studies that show also the quality of life of patients depending on the treatment. And it was interesting to see in the Invictus trial in fourth line with ripretinib that not only ripretinib improves the survival of patients, but it also improves the quality of life. And I think that all the study now should add quality of life data. We are also doing this currently in this study, Aviator, where we are collecting prospective data of patients with the D842V mutation that are treated that are treated with avapritinib. We are collecting the quality of life mainly because of the neurocognitive effect that I told you before. So to conclude, we have a better survival over the time. It is still not sufficient, of course. Fortunately, more drugs are coming. Maybe we will have a fifth line in a few months, and maybe we will have also a change in second line because I show you the trial with bezuclastinib or ripretinib, depending on the mutation. And combination seems to be interesting. New strategies are also coming. With treatment guided by the molecular biology. And the quality of life remains understudied. It gets better, but we need, of course, patients' advocacy input in order to have those kind of study of quality of life in every clinical trial.
Thanks. I think I've never heard such a fast talk with so many slides, so less time. I think we're a little bit 15 minutes ahead of time. So if you have questions, just feel free.
I was talking from a personal perspective now. So you talked about testing for D842V on exon 11. If I got it right, if that was definitely being present then, adjuvant was not useful. Is that right?
Yes, just to be clear, for patients with the D842 mutation, it's called array. I would say that there is no array. I would say that there is no need to prescribe adjuvant imatinib because of two reasons. The first reason is that this mutation leads to primary resistance to imatinib, so imatinib will not be efficient. And the second reason is that this mutation leads to a good prognosis of the risk. So the patient will have a small risk, a low risk to relapse, and imatinib will not be efficient. So for these patients, even if the metinal classification gives you a result as a high risk, I think that we should not prescribe imatinib adjuvant for those patients.
And that's regardless of mitotic count, for example.
Regardless of mitotic count, tumor size, and location. Location is nearly always T3, but yeah.
I have a question concerning this EMAGIS trial. You mentioned that the risk of recurrence is not increased after 6 years. But I also would not expect that it's increased. I mean, if you take the drug longer than 3 years, but just 6 years, nothing will help happen concerning the development of secondary mutations because the KIT receptor is repressed. So I think this is not the question, but the question is whether the additional 3 years add something beneath just pushing the recurrence away. Because, I mean, it's 3 years of additional advantage. For those who take that probably know that they would like to throw it away as fast as they can. So I was wondering what else are the conclusions from that trial? Not only that the risk of recurrence are increased, I believe. Question is whether then patients are cured, for example.
As I told you, for the moment, the results are still immature, but what I've seen is that we have kind of a plateau after 6 years. I think that indeed, for some patients, we only postpone the relapse. But I cannot be sure with that, but I think that for other patients, we prevent totally the relapse. We will need to wait. But even if, of course, 6 years of imatinib treatment adjuvant lead to more side effects than 3 years, of course, but we have also to keep in mind that the impact of a relapse and leading to imatinib for the rest of the life is very, very important. So if we have to have a better and a longer follow-up, but if we prevent some patients from a relapse, I think that it's worth to continue 6 years.
Yeah, but only 3 years you avoid that. It's not that you.
Yeah, we quite often hear that we only postpone recurrence and do not prevent. We have to be absolutely clear that this is completely wrong. The Scandinavian SSG18 study did show a highly significant, persistent for more than 10-year follow-up overall survival difference. So we do not only postpone recurrence, we prevent recurrence with 3 years compared to 1 year.
Yeah.
And that is the reason why 3 years of treatment is the current global standard of care. There is no country in the world where there are any solid recommendations to treat beyond 3 years, but very clear recommendations that 3 years is currently the gold standard. You should not use less than 3 years, but also not more than 3 years. And this is based on the overall survival advantage of 3 compared to 1. So now we have these data from the French study that are very promising, but as you correctly said, we do not yet have any overall survival impact. That does not mean that there will not be an overall survival benefit. But the current interpretation should be very, very careful unless we see an overall survival benefit for more than 3 years, namely 6 years with the French or 5 with the completed recruitment but not yet analyzed rest of Europe study. We will see whether there is an additional survival benefit or not. I personally doubt that it will be there. And whether we think that the progression-free or the recurrence-free survival benefit is sufficient to recommend more than 3 years, that will be a debate, very likely a never-ending debate, or not never-ending, but only ending. There is an overall survival difference seen in another 3, 4, 5 years.
So that would be my question. How long would you wait to get the overall survival benefit? 3, 5, 10?
Well, we did see a consistent, persistent overall survival benefit after 10 years follow-up in the Scandinavian study. There was also already a difference in the earlier analysis, but the more solid data are at the 10-year time point. The French study is quite mature, but not yet with respect to overall survival. So impressive data, and we are very happy that you presented these at a quite small meeting, which I heard was the reason why it was rejected at ASCO, because they said it has already been presented, we don't want to have it, which is completely crazy. But anyway, that's how it went. And now we have to see. We have to wait.
But yet you have patients on a magnet for 22 years, Ned. So we have patients in our chat room who are talking all the time. And there's a difference amongst medical professionals, and some of the leading experts don't come off. Some of the leading experts come off. It's so confusing for the patients. They don't know what to do.
As a case study, sorry, again, the current recommendation is based on the only single study that has shown an overall survival benefit, and that is the 3-year duration.
I get it.
Anything beyond that is an individual decision
Right.
that is not based on solid data, and it should not be done outside of a clinical study. And there is no open study anywhere in the world at this very moment. The French study has been completed and already presented. The Scandinavian, UK, Spanish, German, Austrian, and so on study is also completed. And we have to wait for the results. So 3 years is the current standard.
There's a 3-year versus 5-year study that Ramesh Blusu.
It's the Scandinavian.
That is the SSG22, and that has been completed.
Yeah.
The recruitment has been completed.
The ESMO guidelines are very clear.
Yeah.
In fact, yes, and I think that we have to stay with
Within the
these
guidelines.
guidelines, even if the physician with the patients, of course, is the physician and the patient are both master of the decision. So it could be a personal decision, but the guidelines are very clear.
But I think sometimes in the patient group community, there's a mix-up because of the adjuvant use and the use in the metastatic way. Because I am 20 years on imatinib now, but I'm in a metastatic state, so that's not the into that phase. So that's a different
very
part.
important to make
Well, that's
this
a comparison.
absolutely clear.
So I was 63 was total count on a 7 centimeter gist. On imatinib adjuvantly for margin clear, on imatinib for 1 year, off for a year during this time where they were deciding 1 or 3, and then on for another 3 years, so 4 in total. No recurrence after 14 years. So, you know,
Yeah.
am I lucky?
Yeah. Yeah.
Less like as expected. That's what it is.
Well, that's another issue. It has been shown that when you stop imatinib, but these data also come from the metastatic disease situation. When you stop imatinib and there is a recurrence and you restart imatinib, it will nearly always work again. Nearly always, but the quality of response is less good. So it seems to be the case that the time being off imatinib in a metastatic gist where there are a lot of cells still around, if they are taken off the drug, they start developing complex situations, more secondary and other mutations. So if you restart imatinib, it will help, but there are some indications that it will help not as good as it would have helped if you would have continued. Exactly. Based on that, the recommendation specifically from the French group is that in metastatic gist, you should always continue imatinib. We do have some data, very limited data, that there may be a small group. It's not really well defined. There seems to be a group where there is no recurrence after some 10 years or so. But this group is not really well defined. So if you stop imatinib in a metastatic situation, even with no evidence of disease for many, many years, like your situation, if you would stop, there is a chance that it will never recur, but there is a risk that it will recur. If you would restart, it would very likely help again, but probably not as good as if you would continue. So that has to be balanced. So the current recommendation in the informed consent discussion with the patient is we do not have a clear definition who is the patient who can safely stop. Therefore, it's always a risk, and the risk can only be taken by the patient. Or it has to be taken if the risk of continuing treatment, as you nicely pointed out, based on the side effects and so on. We do see patients with long-term imatinib who have final renal insufficiency. I have seen patients going on hemodialysis based on imatinib.
So if that is the case, then you can recommend stop to avoid hemodialysis, and therefore you have to accept a risk of recurrence. That has to be balanced, but if there are no side effects or no severe side effects, the current recommendation is to continue treatment unlimited. Unless the patient says, I will stop, then it's stop.
Okay.
I don't know factors that are suggested a lot on just because they're unable to handle that.
Currently, there is no indication that it may help for an unlimited duration. The longest duration we have now is something like 23, 24 years. No patient in the world has ever taken it longer because it has not been available before 23, 4 years ago. So we don't know, but there is no given limit in duration.
So given those knowledges, let's say if you had a metastatic disease, you have a choice of really extraordinary or staying on the land, what would be the best course of action?
That's also a problematic misunderstanding. Undergoing surgery in metastatic disease may be helpful. It's not completely understood. Very likely it is helpful, but it is never, ever either surgery or continuation of imatinib. Even if you undergo a lot of surgery, you have always to continue imatinib. And unfortunately, we do see occasional patients who undergo a lot of surgery, are not able to tolerate their drug afterwards because they lost 3/4 of their liver and a lot more organs. They cannot continue the drug, they recur and die. Therefore, surgery is always an addition to continuous unlimited drug therapy.
Is there a threshold in risk versus would you say
it's not versus continuation? If it's surgery, it's surgery plus continuation.
Is there an occasion where, like you said, high risk of surgery could then potentially you got a choice between taking it or stay on it? It's not a fact, it's not a choice, or is that just
if you have to choose, in some kind of situation, if you have to choose between continuing imatinib or doing the surgery, if you have a metastatic disease, there is no choice. It is continuing imatinib. This is the standard, the standard therapeutics. Imatinib should be continued as long as it works. It is the standard. And in fact, you just have to know that surgery, in case of metastatic disease, is not a standard, and it's never a standard. Anyway, there is some cases where it is important, in fact, to think of surgery. I mean, when the primary tumor is dangerous for the patient, you have to think of the surgery. Yes. Or when sometimes there is, for instance, a low tumor burden, sometimes we want to discuss surgery, but it is never a standard. And the only standard in this case is imatinib. And importantly also, what you have to think is that if we suggest surgery for metastatic patients, you have to be sure that this surgery has been discussed in an expert tumor mutational board. Sorry, it is very important, and this surgery has to be done in an expert center with a previous discussion with the experts.
Would you suggest then that a longer like continuing to plan that stops and then look at surgery? You said that's surgery.
No, the current scenario where we would consider surgery is a patient with limited metastatic disease, basically limited to the liver. No peritoneal metastases, just liver metastases. Reasonable time on imatinib treatment with a very good response, and there is some residual disease. Let's say initial, you see G5, 6 liver metastases, you treat with imatinib for 2-3 years. The liver metastases respond very nicely, and there are 3 residuals, theoretically. No peritoneal disease. That would be a patient where we would do a multidisciplinary discussion. And the questions are, is it technically feasible to take out the 3 residual lesions with sufficient quality of liver function after surgery? Second, is there a clear evidence that there is no peritoneal disease? And is the patient aware of the fact that he has to continue imatinib treatment? I've seen so many patients who have been operated, afterwards came see me, and they told me, the surgeon told them, you either continue the pill or you undergo surgery. Yeah, that's crazy. It's not either this or that. It's either you go for surgery and continue the pill, or you just continue the pill and do not undergo surgery.
I guess that's a question. Do you have that really bad surgery? And then obviously when you're on and it takes a lot of heal. Is that the right path? No, John, it's still tell me what's the best way to go.
The best way to go is continue imatinib and not undergo surgery.
Get your residual pulse in.
Nothing it doesn't work for this.
Well, that's a completely different situation. You change the drug to the next line of treatment.
So it's not.
So, do we want to continue that after the coffee break? Then Peter can make his speech, and then we have the panel discussion with all of them again. So,
I'm sorry, but I have to discuss at the TGCT
Okay.
group, so I won't be here for the discussion. Sorry.
okay.
I was just doing one last point about adjuvant. You don't actually know whether it's worked or not, other than if you come off it and the disease doesn't come back. Was it because of the imatinib, or was it because you just decided not to come back?
Yeah. I never know. It's how. Even if the risk of recurrence is 90%.
Yeah. I was told it's not weather, so it's not weather at all, it's when it 14 years later it has. That's when it's
Very unlikely that it will ever come back up.
yeah, you're right.
Okay, we will be here back at 4 p.m.